So, greetings and a warm welcome to everyone. I am Rituparna, the assigned moderator from Clarity. It is my sincere pleasure to extend a heartfelt welcome to all the delegates joining us from across the country today. We are indeed fortunate enough to have the valuable support of the esteemed doctors, and I express my sincere gratitude to each one of you for dedicating your time to be with us today. So, please allow me a moment to introduce our platform, Clarinet. Clarinet is India's largest streaming platform, providing a space for the doctors to create and share innovative medical content. Now, I would like to extend a special welcome to a distinguished speaker, Dr. Vikas Choudhary, sir, who is a prominent consultant radiation oncologist. Sir is holding various esteemed degrees, including MBBS, DNB in radiation oncology, and currently, sir is a much sought after senior consultant and unit head of clinical and radiation oncology at Manipal Hospital, Dwarka, New Delhi. Now, without much ado, I would like to give a brief introduction about today's topic, which is importance of modern radiotherapy in cancer treatment. Radiotherapy plays a crucial role in the comprehensive approach to traditional cancer management alongside surgery and chemotherapy. It serves as a definite treatment for advanced cancers like the head or neck and cervix, as well as offering palliative care. So, without any further delay, sir, I would like to hand over the session quickly to you to further enlighten us on this topic, and kindly allow me a minute to share the screens.
Thank you, Ritu. Thank you for the brief introduction. So, step forward, please. Share the slide number 1. Slides are not visible, please.
So, I hope my screen is visible to you now.
Yes. Yeah, it is visible now.
Thank you, sir. Please go ahead.
Okay. So topic already mentioned by Ritu, power of modern radiotherapy treatment in combating cancer. Please, next slide. So what about the radiation? Radiation therapy uses carefully targeted and regulated doses of high energy radiation to cancer cells. It directly acts on the DNA. So these are the much higher as compared to the X-ray which we use in the diagnostic. Next, please. So types of modalities. So it is external, that is called as teletherapy, and internal, that is called as brachytherapy. Now the new is stereotactic radiotherapy. So teletherapy have different techniques: IGRT, IMRT, tomotherapy, 3D CRT, stereotactic now gamma knife, LINAC, and cyber knife based. Brachy, that are different types of brachyes are there, electronic and the image assisted. Next slide, please. So there is a revolution of radiation therapy in the last 2 decades. Initially, it was two-dimensional, then it moves to three-dimensional. From there, that IMRT era started early 2000, and then IMRT to VMET, IGRT, and now it is going for the proton and adaptive radiotherapies in 2023 and 24. So different techniques have their few advantages and so many demerits. So by this graph, you can see that there is a reduction of normal tissue dose. So as the technology has evolved, there is less and less side effects by avoiding unnecessary dose to the normal tissues. Next slide, please. So what our center have we have the LINAC, which is called as tube beam. It have 120 leaves, and each leaf center leaves are 2.5 mm. They're so thin. By that we can make any kind of the field. Even we can treat a 5 mm brain tumors, and the maximum field size is 40 by 22. So these are the master things which helps to irradiate any type of or any shape, any size kind of the tumor. Next slide, please. So main goal of TrueBeam is to give a powerful beams, flexible imaging tools, highest precision, and ergonomics and automation. So these are technical words which we use during the treatment planning and for particular precision and for high accuracy, because radiation, if goes to it is like irreversible effect if something we done a wrong. Next slide, please. So workflow for the radiation department is like, first we'll take the patient for the positioning, then we immobilize. After that, we go for a scan, that is the RT planning scan. Then we transfer it to our treatment planning system. There we go for a target volume delineations, and then we target, and then we finally make a plan, and that plan is evaluated by us, and finally we go for a QA, that is quality assurance and quality checkup for the treatment. And once we are assured completely, then we start the dose delivery for number of fractions, like sometime 1 fraction, 5 fraction, 10 fraction, 20, 25, and so on. Maximum duration for the even 7 weeks. Next. So different techniques by which the radiation can be given, especially in the external beam, are three-dimensional: IMRT, IGRT, VMET, SRS, SBRT, electron therapy, motion management, radiotherapy. In short, I just want to say that these are different names of techniques, and each technique have some peculiarities about that. So this lecture is very small to make understand this to those who are not belonging to the radiation oncology. Just for the general public and for awareness, we should know that now radiation can be done with motion management, by like with DIBH is one of kind, that is deep inspirative breath hold, especially for the left side tumors, for example, for the left breast, where we can avoid unnecessary dose or to the heart, and different techniques like SRS, which is especially stereotactic radiosurgery. So this, by a single fraction, we can deliver high dose to the brain tumor, and we can treat it in single sittings. SBRT, that means 1 to 5 sittings, and especially we use for the spine at maximum in 2 to 3 sittings. Then for the liver, for the lung, and for other sites also it is coming up, and it may sometime use as a boost also to the normal image guided radiotherapy or the rapid arc therapy. Next. So this is for the VMAT. VMAT means a rapid arc, that volumetric arch therapy full form. That means ki whole gantry move at 360-degree, and dose is delivered at the desired target at the same time, trying to save normal structures or organ at risk around the target. Next slide. So this is IMRT, and this we targeted for the nasopharynx from base of the skull till below clavicle, and in between we try to save centrally located organs, especially larynx and dysphagia associated structures and spinal cord. At the same time, the brain, optic pathway, and the eyes. So this is the most commonly used in head and neck cases. Next slide, please. So this is again IMRT is better version is IGRT. Here we do imaging before going to treat every tumor. This is one of the media. This is for the upper esophagus, which we have planned with including the centrally gross tumor volume and including the draining lymphatic region. Next slide, please. So this is the way in IGRT. Before taking the patient for the treatment, we go for a cone beam CT in our and this console photo where our RTTs work. And in one of the console, it is showing first we take a imaging, we match, and then we do it. Next slide, please. Next. So this is what about the DIBH, what I was explaining in DIBH. When in free breathing, the heart is closer to the left side breast, but when the lung inflate, that it moves away from the target, so we can save heart better in DIBH technique. Next. So this from outside for the DIPH, our RTT commands, they tell to hold the breath and to inspire and to hold the breath and to uh, take free breathing, and accordingly patient get coaching for that and then we treat. Next. So this is for the same treatment. Next slide. So this is for the motion management, especially when tumor is near to the diaphragm. We try to do abdominal compression with the help of the compressing belt so that diaphragm movement can be hold, and then we can treat patient with motion management, and so that there is any chance of the tumor going out of the target become minimal once we do motion management by abdominal compression technique. Next. So this is also in modern era. Earlier we used to do with conventional planning. Now cranial spinal irradiation with the help of VMAT, we can save as much as possible. Next slide, please. So this is electron for the surface. For the surface radiation, especially to the chest wall or to the only superficial tumors. Instead of photons, we use electrons because they don't penetrate deeper in the skin. So we can treat surface tumors by unnecessary going for dose to the deeper structures. Next. Thank you. You can ask the questions.
Thank you so much, sir, for your wonderful presentation. It was really a lucid one. So with all your permission, can we go ahead with the questions? So
Yes, yes.
kindly allow me a minute to share the screen. I hope my screen is visible to you, sir.
Yeah, it is
So over to
visible.
you, sir, for your expertise.
How might advances in genetic and molecular profiling influence the future of radiotherapy in cancer treatment? Yeah, it may, but presently this is genetic and molecular profiling are with the targeted therapies when normal conventional chemo is not working. There it is working, but in RCCs and other where we know, yeah, this is more radio resistant tumor. So we give more higher doses for that kind of the tumors. So definitely it is making a big influence. They already made a big influence for the conventional chemotherapy. Now it is helping for the radiation radiation oncologist to decide the dose particularly for that, and to update the patients regarding after the prognosis for treatment, whether how's the will be the prognosis. Next, please. So, what are the biomarkers or predictors of the response to the radiotherapy in various cancers? So, for the mainly radiation post treatment, we go for the imaging. That is, first image we go for after 10 to 12 weeks, and then we go for after 6 months. So, particularly these are helpful, but particularly when we see about the CA prostate. So many a times there is no imaging is not required. Serum PSA as a biomarker is more helpful than anything else. After radiation, we can check that one, and for other tumors, for the GI tumor, CA 19.9 is the biomarkers, and that can predict, yeah, whether treatment works really well or not. Same like CEA can be worked in for the rectums and other things. So definitely, they we take the biomarkers for the response things, but main concern ours is because radiation is a local therapy, so we definitely do imaging for particular that site. Next, please. How is the radiation dose calculated and optimized to maximum tumor control while minimizing damage to the surrounding healthy tissues? So it is a very complex and system or altogether. So dose calculation, first we prescribe the dose, and dose calculation optimization is done with the help of a particular inbuilt TPS system. So that is either on the Eclipse, one from provided by the Varian, which on which I am working since last 8 to 9 years, and the others are there from the Electa and other. These two are the main players. So they have their systems, Monaco. So on these, they have already approved from the ARB, and it is calculated by the systems. Earlier, it is by manually. Now it is completely computerized. So chances of error are very, very less. Next. Thank you.
Thank you so much, sir, for your
Thank you.
wonderful presentation and addressing all the queries of our doctors. And I would also like to thank all the participating doctors for their continuous participation at the platform and sharing such valuable insights. And requesting you all to suggest any other different topic based on this particular specialty. And we would be very glad to conduct a session on our platform with a suggested topic. Before we close, requesting you all to follow us on our Facebook, Twitter, LinkedIn, and Instagram pages to stay updated with the latest medical insights. Thank you so once again for
Thank you.
generously
Thank
contributing
you.
your time and effort on our
Thank
platform
you.
today. Looking
Yeah.
forward to host you again soon. Thank you, sir. Till then, stay
Thank
safe
you.
and healthy. Goodbye, sir.